VNR-SDG, in partnership with the Economic Planning Unit, EPU, the Malaysian CSO SDG Alliance, and the UN Malaysia Country Team. Now, ladies and gentlemen, welcome back. Let me just get my slides up. Okay, our next session will be our final session for today. This will be strengthening resiliency and transforming healthcare. Now, in the context of COVID-19, health is a major concern and our readiness to face similar crises in the future. Now, we also recognize that health is interrelated to other aspects of human living and the adopting of a human well-being approach. Now, to introduce this topic a little bit further, it gives me great pleasure to pass the microphone over, or the time over, to the interim CEO of MASA as our moderator. Ladies and gentlemen, please welcome Tengku Azila Tengku Aziz. Over to you.
Thank you, Sharizan. Assalamualaikum. Sorry. Okay, Assalamualaikum and very good morning to the esteemed panelists and participants. My session today shall cover the chapter 3 of the VNR report, which is SDG 3, which carries the title of Strengthening Resiliency and Transforming Healthcare. So Malaysia has certainly grown in leaps and bounds in providing quality healthcare since our independence. We now possess an efficient healthcare system consisting of public and private providers, and our health indicators are almost at par with developed countries, indicated in the VNR reports. However, over the past 17 months or so, our healthcare, like so many countries, have been severely tested with the unrelentless COVID-19 pandemic. The realization now to everyone is that health is everything, which is why SDG 3 is so critical. Have we done enough? Can we do more? How can we transform for the better? And how do we strengthen our resiliency? Are we prepared for the next surge of outbreak? And are we prepared for the next pandemic a few years down the road, perhaps? So to discuss this further, I'm indeed honored to have with me distinguished experts who need no introduction. From the government, we have Dr. Rosita Halina Tun Hussein, Director of the Planning Division, Ministry of Health. Representing the parliamentarians, we have Yang Berhormat Dr. Kelvin Yee Lee Wen, a member of the parliament representing Bandar Kuching. He's also the APPGM SDG Treasurer. Our third panelist, I understand there is a change. Professor Dr. Sanjay can't make it, and he will be replaced by Dr. Murali Tharan, Director of the National Cancer Society. And last but not least, our fourth panelist representing think tanks is Dr. Kaw Swee Keng. He is an Associate Fellow at the Global Health Program, Chatham House, and also a Senior Visiting Fellow at the International Institute for Global Health, United Nations University. Welcome, fellow panelists. Thank you for joining this session. As the previous session, the format will be the same. Each panelist will be given 10 minutes to consult and give their feedback on the VNR 2021 report, followed by Q&A session, which has an allocation of 20 minutes before wrapping up. As the timing is pretty tight, we seek assistance from all panelists to keep within a 10 minutes time frame. So without further ado, I now would like to invite our first panelist to take the stage. Representing the government, Dr. Rosita Halina Tun Hussein, you now have the floor.
Assalamualaikum and good morning. Let me just get myself correct. Panel moderator, Yang Mulia Tengku Azila, fellow panelists and acquaintances, YB Dr. Kelvin Yee, MP for Bandar Kuching, Dr. Murali Munisami, National Cancer Society, and another friend, Dr. Kaw Swee Keng. Datin, ladies and gentlemen of the audience, all protocols observed. First and foremost, I would like to thank the organizers for inviting me on this panel today, Strengthening Resiliency and Transforming Healthcare SDG 3. Before I go ahead, can I just see, Tengku Azila, can you hear me clearly, please?
Yes, we can hear you.
Okay, great, thank you. So I want to congratulate the authors and editors, as well as the contributors to this report, especially that of chapter 3. I believe this chapter is well written and highlights some of the key areas within our health system in the context of achievements, challenges, and most importantly, it gives an opportunity to discuss how to move forward to address the key issues while protecting and improving areas we have done well to date. The VNR makes a time series comparison from 2017 to 2019 where available to monitor progress. However, that time frame for the health system in particular may be rather short. Also, a useful comparison would be with other countries of similar levels of development and some benchmarks set by recognized international agencies. Nevertheless, it's still a good report. Since independence, the health system through the guidance of MOH specifically, and government in general, has achieved many milestones and good results. This is reflected in the achievement of SDG targets and indicators as seen in the table in chapter 3. In fact, international agencies such as the World Bank has acknowledged Malaysia's achievement of effective universal health coverage since 1980s through our public sector tax-funded system. Since independence, the public system holds a premium in extending access to healthcare because we long recognize the interplay of health and various social determinants, whereby the poor and lesser educated, the disenfranchised and the disabled have a greater burden of illness. In fact, among the earliest analysis of equity by Meerman from World Bank was a benefits incidence analysis in Malaya, where our education and health systems was the subject. The findings then and still continues to be that the government health system is highly equitable. This is something we should be very proud of and should continue to enhance. Similarly, the incidence of catastrophic spending and impoverishment due to healthcare is extremely low in Malaysia. This is not surprising given that the VNR shows that more than 70% of the population access and depend on the public healthcare system to provide universal health coverage, and it covers 98% of healthcare costs in its provision. However, praises aside, we in the health sector are most sensitive to the challenges we face. And in fact, the Ministry of Health has been looking at various modalities of health reform and improvement for the past 25 years. While we may not have undertaken big bang reform efforts, we certainly have done many incremental changes that allows the health system to remain resilient and strong despite the low investment in health. On this point, the VNI highlights that Malaysia as a country spends only about 4.3% of GDP, and 52% of that is public funding, which is about 2.26% of GDP. This contrasts with average health spending for countries of upper middle income level of about 7% of GDP. And the WHO suggests that for a strong, resilient health system, about 5% of GDP on health should be under public sector management. We are aware that as a nation, we face a huge burden of NCDs, while at the same time facing new and re-emerging communicable diseases. The experience of COVID-19 is a prime example where the two meet in that those with existing NCDs such as diabetes, hypertension, chronic lung problems, previous cancers, etc., have a much more poorer prognosis when contracting COVID-19. Again, MOH has been advocating many interventions against NCDs as highlighted in the VNR. Even while we battle on with COVID-19 through a highly stretched and stressed health system, there is great concern about the continued management of those with NCDs, including cancers. In these trying times of health and economic strain, it is small wonder that mental health issues also come to the fore, as so eloquently captured in the VNR box Article 7. We are living through the challenges of COVID-19 daily, and we can see for ourselves what it is doing to the population, the health system, and the economy. So I feel that I do not have to beleaguer this point further. The question is, how do we move forward? And here again, the VNR provides a few broad, solid suggestions under the 5 headings of enhancing existing healthcare coverage, health system delivery for better health outcomes, intensifying efforts to control both communicable and non-communicable diseases, exploring health financing alternatives for improved affordability and sustainability, prioritizing preventive healthcare approach towards improved health outcomes, and strengthening well-being and inclusivity. However, I feel we need to go further to really embrace the fact that health has to be tackled by the whole of society and whole of government. This is plainly evident in handling the COVID-19 pandemic. The Ministry of Health alone cannot do it. We are fortunate to be able to tap into the ability to contract with private sector providers, especially with emphasis on primary care through various initiatives and mechanisms. These include the PICK, which stands for the National COVID-19 Immunization Program, where the Ministry of Health is able to contract private GPs, private hospitals, healthcare organizations, and NGOs through Protect Health Corporation, which is a non-profit vehicle directly under the Ministry of Health. In that way, we are able to address efficiency and quality of care as we ramp up the vaccination effort nationwide through both the public and private health sector. However, even that is not enough, and we employ a whole of government approach through the National Security Council, NADMA, and CITF. We work with the Ministry of Science and Technology, the Army, the universities, etc. We hope that this effort carries on because we need society and people to play their role. And we need agencies to consider health in all policies, whether it's about how best to open up the economy, up to other policies like tobacco and nicotine taxes, sustainable health financing, and so much more in the future. It is unfortunate that until today, there are those who feel health is the responsibility of Ministry of Health and the healthcare providers only. If I may take small liberties here, and I apologize in advance, it is telling that our panel today, myself included, my esteemed colleagues, are all from the medical field. It would be good to hear someone from the Ministry of Finance or the Public Service Department talking about SDG 3. Maybe someone from industry, employers or employees representing. Maybe someone from industry, employers or employees representing society, and an economist, politician to talk about the state of the health system and policies. So if you can indulge me a couple of minutes more, can I just finish a little bit more, Tunku?
Yes, sure.
All right. Recognizing that the VNR was done some time ago, and the whole world is in an evolving state of flux now, there are perhaps some other points that we need to address moving forward. Society must keep readjusting until we all develop new norms of lifestyle, whether at work, home, or play, even with vaccination, living with COVID as it becomes endemic in society after the pandemic. Recognizing that health is a shared responsibility, the approach to our healthcare system has to be recalibrated. It requires similar commitment and involvement from society, industry, the private and non-government sectors with collective governance and responsibility towards achieving the shared prosperity vision 2030. After all, the health system, with its overarching emphasis on equity, has long held that vision. So why wouldn't we totally want to support that? The Ministry of Health has formulated initiatives to cover various aspects of the new norms of life through the introduction of the National Agenda for a Healthy Malaysia. This was announced by the Minister of Health in September 2020, and the first phase of ANMS emphasizes on 3 main focus areas, which is personal hygiene, environmental hygiene, and healthy lifestyle, very much aligned to the COVID-19 effort. The NMS involves the efforts of various ministries and agencies, including the private sector and NGO, and of course, the Rakyat. So in the interest of time, I'm unable to complete the, well, I have just a tiny bit more. With better policy making at a lower level, we are moving on establishment of an integrated and interconnected health ecosystem that includes not only MOH facilities, but also other government data platforms, population health agencies, as well as private facilities. Efforts to implement an EMR, electronic medical record system, in all MOH facilities are being undertaken with an initial pilot. It will complement innovations from the private sector, such as Digital Health Hub that focuses on 5 core virtual health scenarios, that is telehealth, smart access, remote patient monitoring, drug adherence, and corporate wellness. This is also well aligned to ensuring better data and more granular information at the lower levels of administration and decision-making for better localization and addressing local needs. Now, with regards to the points on the way forward that the VNR has highlighted, it actually aligns very nicely to the Ministry of Health's strategic plan for the next 5 years. This was developed in consultation with other stakeholders across the board within the health sector and beyond. And I think in the interest of time, I need not go through the detail, but it is very much aligned to what's in the VNR moving forward. So I apologize for taking a little bit more time than I intended to, and I want to again thank the organizers for this invitation. Thank you.
Thank you, Dr. Rosita, for your insights and your review. We shall now proceed to our next panelist, YB Yang Berhormat Dr. Kelvin. Dipersilakan.
Thank you so much. Selamat petang, salam sejahtera. For those in Sarawak, happy Sarawak Days. Thank you so much for the moderators, distinguished panelists, as well as fellow colleagues, and also ladies and gentlemen. Thank you so much again for the organizers for inviting me and to allow me to share some of my thoughts. And to be very honest, I'm very excited to hear Dr. Rosita's presentation just now, as well as the Ministry's direction in terms of addressing some of the gaps that we see even in our healthcare, and also moving forward to build a more resilient healthcare system and also ecosystem in our country. But allow me to share some of my thoughts, and a lot of it actually has been touched upon by Dr. Rosita just now. But I think moving forward, I mean, we are really proud of our healthcare system, of its recognition even on international stage, but it is, I think it's very important for us to get the conversation going on gaps that we need to focus upon and to address, especially to ensure continuous and sustainable provision of universal health coverage even in our country. I think in the past 2 years, there has been clear emphasis on COVID-19 itself, and rightly so. But allow me today even to highlight a few, in my view, some neglected issues, maybe diseases and unfavorable outcomes as a result of COVID-19, which of course has been exacerbated by COVID-19, which I think that we need to address and really talked about. I always said this, COVID-19 is a stress test, not just the healthcare system, but also the economy, social security, and many, many others. So it has shown vulnerabilities in our health system, which can have profound implications, of course, throughout health, economic progress, people's trust in government, and of course, social integration and cohesion. It is a reality check for many aspects, as well as the readiness of our healthcare system. I think even though the current COVID-19 has shown that our healthcare system wasn't prepared, and that could be due to, even though it's a new virus, it may be due to years of neglect or even misprioritization, because the healthcare system appeared to be unable to absorb and even manage this sudden and persistent pressure in the workload, especially in acute care. So even though there were contingencies in place, a lot of the healthcare systems, as we can see, were unable to cope with this sudden increased surge in demand. So allow me to maybe touch upon 3 key areas of focus, which I believe is important, I mean, among many. But I think what Dr. Rosita has mentioned just now, I think number 1 is our importance to focus on our battles with NCDs. I think in recent decades, Malaysia's population has witnessed a dramatic surge of NCDs due to our lifestyles, unhealthy diets, and amazing Malaysian food. And we have seen that NCDs account for more than 70% of deaths in our country, including deaths involving COVID-19, where more than 80% of COVID-19 deaths are among those with underlying comorbidities or NCDs. And this itself is a time bomb. Many live for decades without knowing they have undiagnosed NCDs risk factors, and direct and indirect costs associated with treating late-stage diseases such as cancer and kidney disease are, of course, increasing in our country, and this has to be recognized. While I acknowledge that there is recognition of the importance of this, we are currently also under the National Strategic Plan for Non-Communicable Disease, 2016 to 2025, as well. I think it will be an important focus in the 12th Malaysian Plan. But I think there has to be greater urgency, investment, and of course, focus to combat on NCDs. And this goes beyond health sector. It requires multi-sectoral effort and of course, greater investment. The second issue that I'll touch upon, and also again touched upon by Dr. Rosita, is the silent pandemic, which is mental health. We need to focus on, of course, socio-economic inequalities in mental health, even during this COVID-19 pandemics. I do not have to elaborate further on the impacts of COVID-19 on mental health. I mean, it's been reflected in our country. High rates of attempted suicide, high rates of depressive and anxiety symptoms indicates a clear deterioration of mental health over time. And this has severe and serious impact, especially in the long term, especially in terms of the cost to our healthcare system and of course, human productivity. So I think even on my side, on a local level, on SDG level, my office is actively looking at ways how we can increase, train and empower community mental health champions, or what I call community gatekeepers, so that this important focus is translated on a local level, so that while there is a triage of mental health help, but at least on the lowest or local level in the community, we want to identify mental health champions, mental health gatekeepers, so that people know where to go to, and then the triage for mental health aid can happen from there. And that's number 2. And number 3, of course, something that's very close to my heart is the impact of COVID-19 on women's and of course maternal health. This is maybe something not really talked about, but it's something important in my view, especially now that a lot of resources, of course, diverted to management of COVID, which is understandable. But of course, there is a certain neglect on women's health, especially in vulnerable communities. I think not just maternal health issues, psychosexual, reproductive impacts on human health are very essential issues that we need to focus upon. Even in my area, we have noticed that women, especially from the lower income areas, they may have lack of access to proper healthcare, and this includes reproductive healthcare, even contraception, and also they may have higher exposure to even domestic violence that affects their mental health and of course physical health. So the universal lockdown that we have experienced has exacerbated this inaccessibility of proper healthcare, leading to, of course, some unsafe abortions. And this is a real case in my constituency. And of course, as I said, limited accessibility to proper contraception and family planning methods. This again exacerbates even economic issues, especially among the lower income communities. So this is something very close to my heart, and on a local level, one of the things that we are doing with the APPG and SDG is what we call slum incubators. That means we try to uplift the life of the residents living in the squatter areas in the urban setting, in urban poor. Like with APPG, what we did was in one squatter area was we worked with government agencies to provide free mammogram, free pap smears to the women of all ages in this slum and squatters in this constituency. And for the fact of the matter, many of these women, for the first time, were having, they say that, oh, tak pernah, first time having this mammograms or even pap smears. Some elderly ladies say, oh, first time I see a doctor come to my house and ask me all these questions. So these are vulnerable communities that have been neglected and may have not the needed accessibility to good quality healthcare. So I think in conclusion, COVID-19 has exposed and on an accelerated timeline that health is critical for functioning and thriving society. I think pandemic has also placed health at the forefront of global discourse, national discourse, in an unprecedented way in modern times, especially in preparation for future pandemics, which many experts have said will happen sooner than later due to climate change, of course, which exacerbate, of course, zoonotic cross-infections. I think, in my view, we inherited a good healthcare system from the British, but times are changing, and even the British has reformed their healthcare system. So maybe it is important that we get this conversation going, and I'm glad that this VNR has included, of course, broad-ended principles to address it, and they're really good. But I think we need to move further, maybe even to rethink healthcare in our country, including activating a more united healthcare network, reflecting a whole society, a shared responsibility approach that we should be focusing moving forward. I echo what was shared by Dr. just now. Health should not be seen as a separate consideration, a separate ministry, but a priority, a focus in every policy, in every ministry, as we approach the whole of government approach in healthcare. So that's why it's important. I think we build a resilient tomorrow. I think COVID-19 let this be a lesson, let us be a catalyst for us to bring forth focus and transformation in the area of health and general well-being. And with that, thank you so much. Thank you for having me, and back to you, Brazil.
Dr. Kelvin. Thank you for sharing your on-ground experience. It's very interesting to hear, and we'd like to hear more one day. Okay, we'll go to our next panelist representing the CSOs. Dr. Murali, over to you.
Okay, good afternoon, Chairperson. I'm just checking whether you can see me visually and that you can hear me, yeah?
Yes, we can see you and we can hear you clearly.
Okay, absolutely, lovely. Thank you so much. It's, I think, very difficult for me to speak in such a distinguished panel of senior people who are in the health system kind of pocket. I think I've read more of Dr. Rosita's work than ever interacting with her. I think quoted her something like 100 times in my PhD thesis. But yeah, so it's quite a challenging area to speak on. But however, I'm here to represent the CSO perspective, and that's really building on the comments and the feedback provided from our colleagues on the ground. So NCSOs, in the process of creating the feedback for this VNR, we had 3 different sessions attended by 47 different participants, including from rural areas of Sarawak and across from groups working with Orang Asli in Pahang and Kedah and all that. So it's really quite a representative, diverse input from healthcare. And what was interesting is I think both Dr. Rosita and Dr. Kelvin mentioned this on the fact that health literally needs to be bridged across the different kind of areas. One of the beautiful things about APBGM-SDG is the fact that we're all different organizations. Very few of us are working in health specifically, but almost everyone is doing healthcare work. And quite a lot of this input is what I intend to kind of highlight today. And I would hope that you distinguished ladies and gentlemen will be able to kind of bear with me as I run through these pockets. So rather than talking about the problems, I'm going to focus on 5 main areas. We've actually put this up on like a 70-page report, which we submitted as part of the VNR process. And one of the big things that NGOs find to be a big challenge in the ground is that the indicators for SDGs and especially in healthcare are located in the national level. What do I mean by this is you've got big data collection agencies kind of giving a very wholesome picture of your national progress. But for example, in Daerah Hulu Selangor, no one's bothered about looking at how well is Hulu Selangor doing. I shudder to even, and I'm sure Dr. Kelvin echoes me on this, I shudder to even think about certain regions of Sarawak and whether, even is data even captured from those regions, the rural districts and all that. So as much as we like to see national progress across the different SDGs, particularly for the indicators in health, a lot of concern from our colleagues who are working in small places in the ground is that the indicators actually not set on a district level and monitored on a district level. The reason why we say at a district level is that's the kind of most organized political structure, which is at the district level, and the drivers of the SDG are at district level. Your district officers, your pejabat tanah daerah, your PKD, all these exist. And if they can see the need for them to kind of improve their indicators at that level, then they will do some kind of initiation, some kind of interventions, and that will actually provide direct kind of impact onto these small communities on the ground. And I suppose the NGO perspective is never a kind of population level perspective. We're always speaking for the people left behind, the smaller groups, the minorities, the vulnerable people. So that's basically our role, and that is a role that I think we need to kind of do justice to. And YB mentioned this as well. And that one of the problems is with SDG 3 in terms of progress, we're seeing that a lot of this concept of leaving no one behind, we could do so much better in terms of health. So we've got a lot of issues with vulnerable groups, especially from my colleagues who are working with vulnerable groups, those from lower social income groups, single mothers. I even am kind of sometimes worried to mention those of a different gender persuasion. This group is often not even discussed. And of course, migrants and refugees, these are sets of people who have very little access to the overall healthcare system, sometimes by design, sometimes often is just by default. Things like, services provided within office hours, disallow for lower income single earners, people who don't work like formal jobs, for them to even get to healthcare, even though it's free. So it's things like this that, we cannot hope that a formal healthcare system can cater to this last mile. The last mile is always going to be very expensive. And I think across the board, we know that equity has a much higher price than equality, and that cost of providing equity is always going to be superbly expensive. And it's very impractical and I think unfair to kind of put that burden onto a large formal healthcare system. However, there are those, especially I suppose those of us who have a slightly more, I would say, hemorrhagic heart, who work in NGOs and CSOs, and we have maybe a slightly an easier propensity to kind of deliver these services to the vulnerable population. And one of the challenges that we think could be addressed is if we could engage CSOs a little better in a formal setting. Ironically, as Dr. Rosita said, this is the best moment that we've seen government cooperation with NGOs across, I think, possibly the history of Malaysia. Never has CSOs, NGOs that set up been so involved in kind of dealing with civil kind of issues, with helping the health system, assisting. And I think this is the way that we need to move forward with. And if we cannot learn from this, I think it's a very poor time for all of us. I will not waste time in speaking about health system reform. I think it's there's just two words for it. We need political will, and that's, I think, about it. I again, at the sake of sounding very repetitive, I think Dr. Rosita has, and various teams that she has worked with over decades, has, I think, proposed so many brilliant innovations to the system. But I think we've yet to see anybody to kind of take it up. So that's unfortunately the sad reality. For CSOs, the message coming out from us is, look, we're very, how to say, we are ready partners. A lot of us have the expertise and, more importantly, the voluntary spirit to kind of deliver these services into the communities. And what's even more important is, sometimes we can do it for a lot cheaper than anybody else. Currently, we exist in silos, in the sense that whatever services we are providing is not part of the formal healthcare system, not part of the formal kind of bridging mechanism into the overall delivery and provision of services for the healthcare systems. I think we really need to take this opportunity afforded by COVID-19 and kind of stimulate this permanent change. And so, yeah, and with that, I think, again, to reiterate that one of our two big challenges that we're struggling to deal with, we have not transitioned into a health system that can cope with NCDs. We can't pay for it. We don't have the manpower for it. And this is the thing. I mean, a lot of my colleagues from the VNR process are even worried about whether this is an endless pit. No matter how much money we throw at NCDs and mental health, will it ever get resolved? So I think we need to speak about transformational kind of approach to healthcare. It's not about just merely pushing up the GDP kind of expenditure into healthcare and seeing where it's going to improve. Those little incremental increases are, as you can see, the moment you reverse the financial inflow into the system, which is very not sustainable, you see these improvements, quickly revert back. I have my patients. I worked in oncology. All my patients have something like 8-month appointments, simply because we have a system that has now been totally overwhelmed by COVID-19. So it's CSO SDGs as a community, we stand ready to help. A lot of us are entrenched into these communities. We have a lot of social capital, and these are things that I think the formal healthcare system needs to engage with and do it and work with us. Ironically, this is the best time that we've ever had, like, close relationships, the closest relationships that we've ever had with the formal healthcare system across any different kind of setting. I mean, just to share, for example, I'm just taking over 20 over beds from HKL Oncology as they closed the hospital. Even 6 months ago, this is something that would have been impossible for us to speak about. Just the sheer red tape would have killed us all, and in 5 years we would have need to renegotiate or re-speak about this. But the entire process was carried out in less than a day. So we have the will. Now we have been shown the way, albeit, of course, it's a horrible time that we've had to learn the journey through. But I think we need to make use of this opportunity. And so that's about it. Thank you.
Okay, thank you, Dr. Murali. It's always great to hear from CSOs lenses, as you all are the voice of the rakyat. Okay, so the last panelist, last but not least, we representing the think tanks, we have Dr. Koh Swee Keng. Dr. Koh, over to you.
Thank you, Tunku Azila. Let me share my screen and just checking that you can all see my screen.
Yes, we can.
Excellent. I just have 2 slides really, so you can see that it's actually a very short presentation. So with your permission, I will begin. Assalamualaikum everyone, and Selamat Hari Raya to all those celebrating Hari Raya Haji. It's a pleasure to be here. Thank you for having me. I enjoyed the comments by my three previous colleagues. I echo everything they say, particularly that we probably need fewer doctors in revamping our health system in Malaysia, because as we can see from COVID, health is more than just healthcare. More than just hospitals, doctors, nurses, vaccines, and so on. It's so all-encompassing that we probably need a very holistic lens to look at it. And later in my presentation, I'll pitch to all of you that health can replace GDP as the metric for a nation's progress. Allow me to continue. I was asked to speak today about SDG 3, health and well-being, specifically looking at the voluntary national review of Malaysia as part of the SDG implementation process. I will speak from the think tank perspective. I'm affiliated with Chatham House, ISIS Malaysia, very proud of it, and the United Nations University. But I come from a previous career in practice, so I'll share some of my thoughts that, shall we say, intersect between practice and the think tank sectors. I'll proceed. This is one of only 2 slides. And in this slide, I would like to share some observations about the VNR for 2021 focused on health. It's about 8 pages. These are my 3 observations. The first one is to say that voluntary reviews like this VNR process are a part of global accountability, and we must take this seriously. And I'm glad that Malaysia takes this very seriously. A voluntary review is, shall we say, step 1, but there are other steps, right? Just conceptually for everyone, you can be reviewed by your peers. You can be reviewed by an external group of experts like in the International Labour Organization, or for nuclear or weapons inspections, there is something called an unconsented review. So voluntary reviews are really the lowest tier in global accountability mechanisms. Malaysia's National SDG Council and the Steering Committee have 6 working committees, inclusivity, well-being, and so on. But health cuts across all of them and perhaps cannot be siloed only in the well-being working committee. And similar to comments in the first session this morning about poverty, the VNR process for Malaysia for health must be integrated with Malaysia Plans 11 to 13, Rancangan Malaysia 11 ke 13, the National Recovery Plan, the National Recovery Council, the Shared Prosperity Vision, and every other government vehicle out there. So they cannot exist as a silo by itself. My second observation about VNR is in the second box, that statistics are necessary, but they're imperfect. Here's why. SDG 3 has 13 targets and 40 indicators. Broadly speaking, Malaysia achieves these indicators. We've got excellent news, especially in maternal mortality rate, infant mortality rate, malaria, and tobacco. But these SDG goals and targets are minimum standards. Minimum standards in the sense that Malaysia probably achieved them in the 80s, 90s, and noughties. So we really don't have anything to celebrate if we've actually achieved these SDGs. So perhaps Malaysia should rely on higher standards. So desired standards like OECD standards or a basket of peer upper middle income countries. So that could be a better target for Malaysia. But other, shall we say, issues or thoughts to consider broadly for the VNR process is the methodology robust? Are the indicators leading or lagging indicators? Is the data collection decentralized? To my colleague, Dr. Murali later, are we collecting data from Kuala Selangor or Taiping, where I'm from? Do we collect data, again to Dr. Murali's point, do we collect data for non-Malaysians residing in Malaysia, or is that data only for Malaysians in Malaysia? And because we're all human beings and part of the same species, we probably have to collect data for everyone in Malaysia to be truly accurate and inclusive. To Dr. Rosita's earlier point and to Dr. Calvin's earlier point as well, to what extent is the Ministry of Health responsible for success or failure? We've got all these beautiful metrics, right? Target for tobacco, target for malaria, and so on. But a lot of it is also not dependent on the Ministry of Health. Ministries of Women, perhaps even Finance, Transportation, Rural Development, Economic Development, EPU, and so on, are all very relevant for the success or failure of health metrics. Are we, my fifth issue as we continue is, are we targeting targets? What I mean is we're just working towards those targets without thinking about how we're achieving those targets. And finally, does SDG just encourage busy work? We just collect this data and we feel good about the data, but we're postponing the necessary and very difficult reforms. Here in the third box are some emerging health issues in Malaysia. The first 2 are captured inside the VNR, so I'm very pleased with that. The out-of-pocket payments in Malaysia are increasing. Now is at 40% of total health expenditure, and the WHO recommendation is 20%. This causes catastrophic health payments and bankruptcy. So the AKPK, or Agency Counseling and Pengurusan Kredit, which is an agency of Bank Negara Malaysia, estimates that 18 to 20% of people who go bankrupt in Malaysia go bankrupt because of health reasons or health spending. The second emerging health issue captured in the VNR is that late-stage cancer diagnoses are increasing. Just as one example, breast cancer diagnosed at stage 3 or 4, sorry, there's a mistake there, not 3/4, right? There's no such thing as stage 3/4, but breast cancers, people with breast cancer diagnosed at stage 3 to 4 are actually increasing from 43% to 48% of all cases in the 5-year time frame leading up to 2011 and 2016. The point I'm making here is that this is one metric, but there's a whole host of sub-metrics surrounding it, like education, like cultural barriers, like the determinants of health, like financial barriers to access. And all these things come into play in one metric that we then use as a bit of a blunt instrument. There are a few things not covered by VNR. The distribution of health professionals, the increasing role of private sector in the political economy of Malaysia's health. How do we measure the resilience of public health and public health care? And these are separate things during an endemic COVID for multiple years. And also it doesn't capture aging. Ladies and gentlemen, these are my observations from the VNR. I was asked also to speak about opportunities and ways forward. So if you allow me the privilege of this slide, let me share 3 opportunities and ways forward. Firstly is to consider endemic COVID in blue on the left of the screen. We're fighting essentially a triple burden of care. We're fighting COVID, we're delivering routine non-COVID care, and we're delivering overall public health, at least until 2024. Now, SDG will be impacted. A question for all of us, including the Secretary General of the United Nations, is, do we need a COVID target or an indicator for SDG 3? Malaysia requires, secondly, a political stability for health. And in that political stability, I prefer not to comment about that. How do health professionals interact with political leaders to achieve SDG 3 and COVID goals? Thirdly, health in all policies. This is not conceptual, this is practical. MOH alone is not enough, as we've all agreed. Organizational changes in rearranging the government a little bit may be necessary for effective coordination. What I mean is, do we need in Malaysia a coordinating ministry for health, similar to what they do in Indonesia or Singapore? Or do we need China's National Health Commission? In China, health is so important that it's one of only 3 commissions, the other being security, the third one being economic development. So do we need a way to reorganize our cabinet as well as ministry agency structure so that we can have health in all policies? And earlier I mentioned health as a new GDP, which is a concept that will not be unfamiliar to all of you. Secondly, let me move on to the health systems and the 6 building blocks of health systems. If you Google 6 building blocks of health systems, you will find excellent resources on the internet. But I've listed the 6 of them down there, and I'll give some examples about different things that we need to do in the VNR process to improve our health systems. Let's go through them one by one. The first one is human capital, as in the contract system needs to be resolved, the maldistribution of doctors between Sabah, Sarawak, poor parts of Malaysia with the urban parts of Malaysia needs to be resolved, and the retention of doctors so we don't lose them to the private sector or to Singapore, Australia needs to be resolved. In healthcare delivery, there is no perfect mix, but we'll have to find the right mix for Malaysia between preventive and curative. And here's a terrible statistic. We spend 10% of our total health expenditure in MOH on preventive and 70% on curative. So I'm sorry, the number is 7 and 70. So it's a 10 times difference. So 10 times more on curative versus preventive. We need to find the right mix between public and private, and the right mix between primary care, as in GP clinics, all the way to tertiary care, like university hospitals, as well as GHKL. In financing, to diversify the sources of funds and to increase the accountability for the users of funds. We need better procurement for all the vaccines, medicines, and technologies out there, and more domestic production. Portable lifetime electronic health records so that we know what's going on in health terms, at least for populations. And in terms of leadership and governance, potentially removing Ministry of Health conflicts of interest, in a sense that right now they are standard setter and regulator, but payer, provider, and even sometimes asset owner through other government agencies. And there's also a need for decentralization of health decisions. To that end, allow me to perhaps propose something to everyone. It's within the VNR process, but also outside of it, because VNR is only capturing one part of our progress. It is to have long-term health reforms that begin with creating a health reform commission through an act of parliament. Let's create this one. The name doesn't matter to me, so let me call it a health reform commission. 10 years of operations. It will define and guide the reforms for health in Malaysia. But after 10 years, it's replaced, transformed, changed into a health commission after year 11. This health commission is responsible for the steady state management of health system, including setting strategy and standards and managing human capital. The MOH then becomes a regulator and a policy setter and also delivers public health. And then we can have hospital trusts and a network of general practitioners and primary care practitioners to become the healthcare providers. This could exist alongside the VNR as well as outside of it. Ladies and gentlemen, we all know that health is very important. I'll spare you the rhetoric. Health is a political choice. As much as it is a scientific choice and making evidence-based decisions are a crucial part of healthcare, if you truly want better health for all Malaysians, to quote my colleague Dr. Murali earlier, political will is needed, and therefore health becomes a political choice. Thank you for having me. Over to you, Tunku Azila.
Okay. Thank you, Dr. Koh. It's definitely an interesting presentation, and I must say that you speak very fast. Okay, so it's now time, since we've listened to all the panelists giving their reviews, insights, on-the-ground experience, feedback. We shall now open the session up to questions and answers. So let me go to questions and answers. We have received 7 questions. So how I would do this is we'll go through the first, maybe the first 2 questions. Oh, so sorry. Let's go through the first question first, and then anyone on the floor is free to comment on this. At present, this question comes from Melanie N. Yin at present. How are the SDGs guiding the government, particularly the ministers who are now making policies that are directly impacting the rakyat? Is there a commission that is pushing for this at this critical time? Would Dr. Koh like to say something?
So sorry, Tunku Azila. Who asked this question? Who asked that question? Rather, I'm looking at the chat, but couldn't find it.
It's in the Q&A text box.
Right. And may I ask who asked it? So sorry, I couldn't find it.
Oh, it's the bottom icon on.
No, I mean, I saw the chat box, but who asked this question? Or which question was it?
Melanie N. Yin Yo.
It's the topmost question.
Oh, right. Okay. Oh, thank you, Dr. Rosita. Got it. Melanie Ann Yin Yo. The question, if I may repeat for everyone's benefit, at present, how the SDG is guiding the government, particularly the ministers who are now making policies? Is there a commission that is pushing for this at this critical time? Tunku Azila, I'm afraid I don't have a good answer to this. So I'll provide some intro comments and then maybe hand it over to somebody, perhaps Dr. Rosita, sorry to put you on the spot. On paper, there is an SDG commission, council rather, that is chaired by the Right Honourable Prime Minister of Malaysia, Muhyiddin Yassin. So that's on paper. And there are 6 working groups, as I've described in my presentation earlier. Health is in one of those working groups, the well-being working group. But because health is so cross-cutting, it should probably be involved in the other 5 working groups as well. I just don't know whether or working committees is a specific technical name for it. But I just don't know whether or not health is engaged with these or not. And I think that, so that's my first comment. My second comment is about the voluntary nature of VNR and the fact that it takes place every 3 to 4 years or so. So the actual duration is not specified by the United Nations, but I think it takes place every 3 to 4 years. So there could be more tactical things that needs to happen. For example, weekly cabinet meetings every Wednesday. Number 2, there could be the Rancangan Malaysia plans that are anchored by EPU. And thirdly, the National Recovery Council, which I hope will meet very often as well. Thirdly, and finally, Melanie, I've given the public administration element. Secondly, the fact that there are different routines. Thirdly, and finally, Melanie, and maybe I can say that fortunately for us, a lot of the SDG goals are very reflective and overlap with all our national goals as well. So it doesn't matter really whether or not you follow the SDG regime or you follow the NRC regime or the EPU regime, as long as we're making progress. Thank you, Tunku Azila. Over to you or to Dr. Rosita.
Okay. I would like to call Dr. Rosita to also comment on that. And Dr. Rosita, you have a specific question, the second question. Have you read it?
No, I haven't. Let me just look at that.
The second question is from Muhammad Azmi Muhammad Rashid Khan. Dr. Rosita, again and again, we've heard of how unaffordable high-quality healthcare is for the middle, lower-income households, let alone the underserved and vulnerable population. I've just also heard how an old lady checked herself in a private hospital for a certain ailment, only to find out she's COVID positive, and her bill came up to 43,000, which she can afford, and community had to raise it. This moves. Okay, so both VNR reports of 2017 and 2021 mentioned exploring healthcare financing alternatives as a way forward. Would you care to comment?
Sure. Well, going back to the first question, as Dr. Kaur said, indeed, there are already government structures that monitor the SDGs at a higher level, and the different line item ministries, also monitor. But I go back to Dr. Kaur's earlier presentation. For Malaysia, I think a lot of the SDG indicators, we have exceeded them. You must understand that the SDGs are set up to fit the whole world. And so we have highly developed countries and less developed countries. So the SDG ends up somewhere in the middle. So it's very, very important for Malaysia, as I suggested earlier, to look at comparator countries, upper middle income countries, even aspiring looking at the new developed countries, and also benchmarking with certain indicators that's put forth by certain international bodies and agencies. So that is the case for the SDG monitoring. With regards to the cost of healthcare, and again here, when we talk about the efficiency of healthcare, I think, and this is going to be highly unpopular, I think, with many people for me to say this, but the efficiency of healthcare is really in the public sector. And that's where we gain a lot. And now I apologize, I don't have my usual slides for that, where we show the comparison between the funding for healthcare, both which goes to the public sector and the private sector, and the actual utilization and delivery of healthcare within the two sectors. So I'm very sorry to hear of the story that was in the chat, but it is not, unfortunately, it's not surprising. This is where we have tried for many years, and so I was, in preparing for this talk, I was thinking about how many years I've been doing this, and it comes back to 24 years. That's 24 years of talking about trying to move forward on things. And there are many stakeholders, and it's, when we talk about political will, it's not just politicians, but it's the political will of many, many stakeholders, whether to agree or disagree. And so, like Dr. Murali says, I know COVID is a terrible time, but in a way also it is a good time for us to really take stock and understand how important the healthcare system is. So I hope that's something. Did I address the question, Madam Moderator?
Yes, I believe you did.
Thank you.
Thank you, Dr. Rosita, and thank you to Dr. Kaur. Let's go to the next question. Okay. From Anonymous, how does care for the environment contribute to good health, well-being, and sustainable development? Perhaps we can call on YB, Dr. Kelvin. Would you like to comment on this?
I think I'll just give a very short comment. I think even from the presentation and the sharing just now, and even from previous sessions, I think it is accepted that many diseases are very closely associated with, environmental factors, poverty. The fact of the matter that COVID-19 itself is of zoonotic source, according to many experts. So I think, if I'm not mistaken, even the WHO has estimated about 25% of the disease burden in all developing worlds are due to environmental factors. And this is something that we need to address, and especially even preparation for future pandemics, because as I mentioned, even just on my presentation, with climate change, this is a catalyst for even more zoonotic infections to come into our community and society. And this is something that we need to protect. We need to have one health, rather than focusing on health as a department, a ministry, or one sector itself. It has to be an ecosystem, and this ecosystem covers everything, which is the welfare of the person, basic necessities, basic utilities. I mean, the fact in Sarawak, for example, a lot of the health issues that a lot of the people, especially in the rural, are due to lack of basic necessities. I can give you one very clear example. Patients, dialysis patients, peritoneal dialysis patients, when they go back to their villages, sometimes they don't have a stable water supply and stuff like that, so they have to go to the river to take a bath. And with the river's water being contaminated and of not clean source, sometimes you get infection, peritonitis, and then you get other complications, so on and so forth. So again, it has to be a healthcare ecosystem. We need to look at health not just on one single factor, but the whole ecosystem. So with that, back to you, Dr. Azila.
Okay, thank you, Dr. Kelvin. Dr. Murali, would you care to comment?
So I think it pretty much encompasses what everybody else is saying, which is, you've got I think we're doing well for about 60-70% of the population. And we're doing well at providing them with the kind of access and the quality of healthcare that is adequate. Now, what we need is actually to bridge the resources that we have abundantly in the private sector, sometimes which is very, very underutilized. And as Dr. Rosita put it so eloquently, I think there's no one who's as efficient as the government in providing healthcare. I think we need to realize that. What is this? However, we've got a lot of resources which are kind of siloed away in the private sector. Could they be put to work together with the government sector? Of course we could. And I think one of the greatest success stories of this is Protect Health. Despite a lot of kind of initial apprehension, fear, concern about this being that came into creation, I think it has successfully told its own story. And it's telling you that this is the way that we can buy services from the private sector, but at the same time maintaining the cost efficiency and the quality of delivery. So slowly, the Ministry of Health will, I suppose, need to move into the role of oversight, rather than as functioning on the ground as providers. And once we start doing that, once we start that transition, which of course, unfortunately, until you can see a real significant health system reform, which involves who's going to pay for this, because money makes the world go round. Let us not kid ourselves, and until we can do that, we're going to be stuck in this conundrum. We'll never be able to cover that last 30% of our population. And it's not only in terms of the geographical disparities. We talked about there's a huge amount of geographical disparity that cannot be denied. Just to tell you a common joke running between all of us is, if you want to get cancer, you should always get cancer in KL. If you get cancer in say, Perlis, you did, man. You're just better off dying. But this, other than this geographical disparities, there's these vulnerable populations that we spoke about as well. And there's disparities across the diseases. Even in cancer, there's some cancers are more equal than others. Let me put it that way, in terms of funding, in terms of access to drugs. And this is just within the oncology pocket. We haven't even spoken about NCDs. We haven't spoken about how, diabetes, cardiovascular, it's just a huge amount of disparity across even the different diseases. So when you segment off like the different populations with the different diseases, you then see pockets of kind of inequities popping up all across the system. But currently, with the tools that we have, we will not be able to fix it. So really, there needs to be a paradigm shift. We're doing better at moving the needle towards that edge, and this is what we hope to continue kind of sustaining after COVID ends, if it doesn't within this next century or so. I'm sorry.
Thank you, Dr. Murali, for your answer. We'll now go to the next question. Actually coming from Sharizal Sharani, which is a dear friend of mine. I think this is for me, actually. I think it's a good idea to establish the Health Reform Commission. Would this be something EPU and MASA would advocate? Thank you, Sharizal, for putting me on the spot.
Oh my God, Puan, before anybody comes in, I just want to say it's been done to death. As Dr. Rosita was telling you, she's been working 25 years on that, you know. If we do another reform, I think we need a reform to the reform.
Reform to the reform to the reform. So Sharizal, that's your answer. We can discuss this with EPU, of course, and of course VNR-SDG, who is our partner for this event. Okay, we'll go to our next question by an anonymous. With our population that will face an aging society, this was mentioned by Dr. Kaur, did the system of public health have the capacities and capabilities to safeguard and sustain the rakyat's health and well-being?
Tunku Azela, if you permit me, may I respond briefly to the idea of a health reform commission?
Oh, yes, okay, go ahead. That was your
Thank you. I think Dr. Murali is right. We have done multiple reforms, and by my count, 16 to 20 attempts in the last 40 years. So that's one attempt every 2 years. Since the 1980s. Some of this were EPU-led, some of this were PMO-led, some of this were cabinet-led, some of this were, very few, I must admit, were MOH-led, but I'm not familiar with the history. I'm not trying to tell anyone the history. The point I'm making is multiple people have tried to reform the system, but usually from the outside. What I mean to say is consultants will come in, they write a report, then they leave. Ministers come and go. The average health minister in Malaysia stays for only 3 years. That's the problem I'm trying to resolve, which is multiple people come in and out of the system and then try to reform the system from the outside. Excuse me. Any reforms will probably then have to be timeless and built in with MOH at its core. But MOH cannot reform itself while still doing its work, right? Therefore, the least imperfect solution, short of a health minister who's there for 10 years, right, is to create a parliamentary act of parliament, health reform commission, responsible and accountable to parliament. So ministers come and go, but the reform commission stays until their job is done, and then they hand it over to a health commission. No more reforms after that, because we can't continually reform the system. That's the thinking behind it. Pause here. Maybe Dr. Rosita might have something to say.
Thank you. I think since we've been trying this for the longest time, I have to say, first of all, Ministry of Health never stops trying because we believe that it's important enough. It is about it is about the economy. We're talking about healthy people, healthy workers, good economy, etc., which oftentimes the other segments of the government, other segments of society forget that. So in that sense, we will look at all avenues, but I think the important thing, what we have achieved through the many years that we've been talking about this, is exactly what Dr. Kaur said. Before, this was very much generated by consultants, external people, and we just got the report. But I think through the years, part of that has also built up a cadre of people within Malaysia, within the government, certainly within the Ministry of Health and the health sector, who understand what we're talking about with regards to health reform. I think one of the biggest challenges that we still face, and this is why when I made my talk earlier on, I was saying, it would be good if we had somebody from Ministry of Finance or somebody from JPA on the panel, rather than all us medical people who are basically sold on the idea. But because I think people forget, they talk about health as a commodity. They talk about, the health market as though it's a perfect market. And they forget also the societal and equitable issues related to health, which, of course, even the most perfect market doesn't address equity issues. And what more, a failed market like the healthcare system. So in that regards, with regards to a health commission, as long as it's all inclusive, it's inclusive, and it has the people on board who understand what the issues are, who are maybe have got a more broader understanding of what health systems should achieve. I'm sure Ministry of Health would be happy to look at such things or to discuss such matters further. Thank you.
Thank you, Dr. Rosita. We have time for one last question because we're nearing the end of the session. The question comes from Bina Ramanan. Non-citizen children born overseas to either parent Malaysian do not have access to government healthcare at the same rate as Malaysians. There is also the intersectionality that some of these children are physically challenged or require long-term medical treatment. Many of them are single mothers and have challenges paying for the healthcare of their non-Malaysian children. When will there be inclusivity in not leaving them behind under SDG 3? I would like to open the question, perhaps to Dr. Koh.
Thank you, Tunku Azila. This is a challenging question to answer. And firstly, we're all concerned about this, and we hope that there will be some short-term solutions for each of these children who require medical attention, and also long-term durable solutions for the whole system, so that we can we don't have to be heroic, right? Medical care shouldn't really be heroic. The system should be able to save 99% of the cases, and only 1% of the time do you need a doctor who becomes heroic. And I don't like heroism, generally speaking. Coming back to the issue at hand, I think that there could be two things here that we need to can think about as a systems solution. One is a durable solution at the intersection between immigration and, shall we say, non-citizens' rights. Some of us in civil societies have actually written a proposal called a Non-Citizens Health Act for Malaysia. This does not mean that we will take taxpayer money and endlessly fund healthcare for non-citizens, because at some point we have to draw the line, and we have to be equitable and to be respectful of the rights of citizens and taxpayers and voters of Malaysia, as well as our national sovereignty. But leaving that aside, I'm sure we can find a balance between national security, sovereignty, etc., as well as our moral imperative to take care of human beings. So the first systemic solution, durable systemic solution, is a consultation or some sort of partnership with the immigration authorities and the Home Ministry and the National Security Council to resolve this issue. This is one. The second systemic solution, right, that can be both deployed short-term and long-term, small and big, is the safety net that includes NGOs. Like Dr. Murali was very right when he says that NGOs should not be the first port of call for the majority of people. But NGOs are very good, shall we say, at filling in the gaps where governments cannot go. And no government in the world will ever be able to go and fill every gap in society. So the government then perhaps should consider, must consider, or must build an infrastructure and ecosystem that enables, allows, encourages, motivates, incentivizes, makes it easy for NGOs to fill in these gaps. These are the two systemic solutions that we can provide, short of donations on an ad hoc basis. Over to you, Tunku Azila.
Okay, thank you, Dr. Koh. Would like to also invite YB, Dr. Kelvin. Would you like to say something on this issue, as this affects you? I'm sure.
I think I couldn't add as much. I cannot add more to what Dr. Koh has mentioned. Again, this involves political issues because I understand that a lot of these children, they are actually Malaysians born to Malaysia's parents, and there is a constitutional inequality. Let's put it in a federal constitution that does with this. So again, there has to be some political will, which I am personally very supportive of a reform to give equal and equitable treatment to both gender, and also for children born to not suffer the effects due to decisions made by the past. And this is not just born overseas, but I think even in Sabah and Sarawak, I mean, as well as some Nigeria, Malaysia, there are a lot of children, undocumented children born in Malaysia, but undocumented. And this creates issues, not just access to healthcare, access to education, and actually at the beginning in Sarawak, there's access to even vaccination. So this is something that we need to address. Children shouldn't be punished for decisions of the parents. And I'm talking about maybe other social causes. I think there has to be political will, and I am fully supportive of such reforms, even constitutional amendments with that. So with that, thanks, back to you.
Okay, thank you. Thank you, YB Dr. Calvin. So we have reached to the end of the session. For the other questions that were not answered, we will send it to the Secretariat, and we will hopefully get it answered to all the participants here. Before wrapping up, I hope the MC, can you give me about couple of minutes more?
Sure, no worries at all.
I'd like to invite each panelist to share with the audience.
Okay.
If you could provide one key takeaway that you'd like all of us to remember, what would it be? Maybe 1 or 2 minutes each. Dr. Rosita?
Thank you, Tunku Azila. I think my key takeaway would be that, as negative as this sounds, health reform is not a simple thing, and there's no quick solution. But having said that, I'm very happy if more and more people get involved and understand the issues behind what we need to tackle, so that as a society, we become more responsible towards our healthcare and our healthcare system. Thank you.
Okay, thank you, Dr. Rosita. YB, Dr. Calvin?
Thank you so much, Tunku Azila, and I'm very grateful to be able to share this stage. And I think the main takeaway for me is I think there has to be a rethink of how we look at healthcare, even in our countries. I think a lot of previous systems may not apply, and I think, okay, COVID-19 is a horrible pandemic, but the one blessing in disguise is it brought healthcare to the forefront of the conversation, and people is talking about healthcare like never before. And suddenly people realize that healthcare is not just MOH or it's just the doctor's jobs, but it encompasses every sector. And that is why we need to continue these conversations. Reforms have to be rethink, mindsets have to be changed, and tough decisions have to be made. And I understand even healthcare financing is something that's very close to my heart, but I understand even the political will to do that is difficult, because no political party will win an election if they propose charging more for healthcare. But it's something we need to talk about, and I am fully supportive of the Healthcare Commission, because healthcare is a long-term reform. We cannot, while I appreciate healthcare ministers coming in to bring in their personal initiatives, but we cannot be changing healthcare direction based on which YBMK is in power. It has to be a long-term thing. So with that, thank you so much for having me. Thank you, Tunku Azila. Back to you.
Thank you, YB. Over to you, Dr. Morali.
Thank you, Dr. Azila. I think everyone's put it quite succinctly, but reform doesn't really take money. Reform requires a lot of simple steps in reform, just need kind of everybody to get on the same page. COVID has forced us to get on the same page. For example, we tried 5 years to move patients into the private sector from public hospitals. Within 1 week, with the emergency declaration, we can move patients across from private to public. We have a simple, this doesn't cost money. for example, our consultants cannot work, our private consultants can't work in public sector, and a lot of them are willing to, donate time, donate effort. And these are things that don't cost a lot of money. Reforms need to start slow, and most importantly, the successful reforms need to be told, because they, in turn, the good publicity generates the capacity to do more reforms. And the cheaper the reform is, the more, the less money, the more bang for the buck that we can get out of it, the more it is we are able to convince people and politicians that we can then spend the money that is required. It's not all about the money; it's about the collective effort and, more importantly, the will to do so. And I think that's we have seen that we can get that will together, that bipartisanship, or actually, reaching across all the different levels of stakeholders, of civil society, of government working together to get over this nightmare. So what's important is that we do not forget how to do so again. And, while doing that, then we can lay perhaps a reasonable seed for us to start on that long road to the future.
Thank you, Dr. Murali. And last, Dr. Koh.
Thank you to Azila. My final thought is to introduce the concept of a health new deal. The health new deal as a result of COVID, because this provides a unique political opportunity that we cannot miss. We just simply cannot waste this crisis of COVID. The health new deal actually has a bit of a history. In 1920s, when there was a Great Depression in the US, President Roosevelt came up with the New Deal, which ushered in a period of a dramatic infrastructure rebuilding in the US. After the end of the Second World War, the National Health Service was born in the UK. After the 2009 financial crisis, the Financial Stability Board was built in order to make sure that there was never a second or a subsequent global financial crisis. These three examples, the New Deal after the Great Depression, NHS after the Second World War, and the Financial Stability Board after the 2009 global financial crisis, means that if you put political will with political skill and aided by able technocrats like Drs. Rosita, Kelvin, and Murali, we will be able to deliver a health new deal for Malaysia. Let me end on that note. Tunku Azila, thank you very much, and over to you.
Thank you, Dr. Koh. Thank you, fellow panelists, for all your sharing. It's very exciting. Everyone comes from different perspectives. An insightful session, and especially coming from distinguished experts like yourselves. So to conclude, I'd just like to sum up this session. We've heard from all the panelists, and there is a consensus that the government has done a commendable job in providing healthcare to the rakyat of Malaysia. And also this was depicted in the VNR 2021. But as always, there's always room for improvements. For example, in the cases of NCDs, mental illness, methodology of data collection, distribution of health professionals, measurement of resilience, silos in utilization of resources in the case of the CSOs, and amongst others. And this all needs to be accelerated now that COVID is here. And I think most of you also said that this is a blessing in disguise, a silver lining. COVID can be and must be taken as a catalyst to improve our healthcare system, and public policies can help with the new GDP. Should we create a health reform commission? Is the SDG benchmark enough to go, or should we go for higher targets? As one of you said, SDG only covers the whole world. In short, everyone agrees that moving forward for health reform, number one, we need political will and collective effort. Number two, health is a shared responsibility and requires a multi-party approach, public, private, CSOs. Healthcare is not solely the responsibility of MOH and medical providers, but also every sector of the society. And I hope all of us who are not doctors like myself will remember and digest that. With that, I thank all the panelists, and I wish you a good afternoon. And I will hand this over to our MC, Shariza. Over to you.
Thank you so much, Tunku Azila, Tunku Aziz, for moderating this session. Also, thank you to Dr. Rosita Halina Tun Hussein, YB, Dr. Kelvin, Dr. Murali as well, and Dr. Kaur for this session as well. Thoroughly enjoyed it. Yes, medical reforms are needed. I like the part where you said political will and skill, but I think we also need that political unity to get things moving as well. In times of urgency, things get moving, right? So hopefully there'll be more urgencies to come to get these reforms into place as well. Well, thank you once again to everyone. This is concludes our very first session for today. Don't forget to join us again tomorrow at 9 a.m. right up till 1 p.m. for our second day. And also to all our friends who or participants who are in here as well, thank you so much. We will be posting a what you call that, a feedback form into the chat box that we would need your assistance to fill it up for us. Right after the session, we shall put that link up for you. Well, everybody, thank you so much. Thank you, Institute Masa Depan Negara as well, for coming on board for this as well to initiate this. And also, we'd like to thank our friends from the All-Party Parliamentary Group Malaysia on Sustainable Development Goals, APPGM-SDG in partnership with the Economic Planning Unit as well, and the Malaysian CSO-SDG Alliance and the UN Malaysia Country Team. And with that, ladies and gentlemen, have a great day, great lunch. I'm sure all of you are hungry. You need that second cup of coffee as well. Till then, we'll see you all again tomorrow at 9 a.m. Thank you very much. My name is Sharizan. Have a great day, everybody.